Guys, I'm just going to kind of go quickly through shoulder stuff. The talk could go on forever, but I tried to do things that you all may see more in the acute setting and whatnot, and at the end I'm going to briefly go over some rotator cuff stuff. So we're going to briefly go over the shoulder anatomy. If you know the anatomy, then it's pretty easy to figure out what was hurt and what you have to do. And then some of the common problems: shoulder instability, shoulder separation, AC separations, clavicle fractures. Very common, and then just a few more chronic things, but extremely common. That this will probably, you'll probably be talking to this more with the coaches rather than, or if you are a coach, this is probably your problem rather than this other stuff. So just so you have knowledge of it. Shoulder anatomy. Shoulder gets in trouble a lot because it has so much motion. The socket, the glenoid, is very flat. It's like a little saucer dish. And actually, the best way to think about it is a golf ball sitting on a golf tee. So very little bony support versus the hip or the knee. And then this glenoid, the socket's, again, only about a third of the diameter of actually the ball. So lots of muscles around it provide support for the joint. This is just a picture showing everything. And again, you think of the shoulders just here, but it's the shoulder blade, because the shoulder blade, the scapula, is the same bone as the glenoid. Okay, and then the shoulder blade kind of comes up and forms the acromion as part of this AC joint. And then you have the clavicle. So it's all related with lots of muscles attached. And you have the rotator cuff in here, which I'll talk a little bit more about. But everything here, anatomically, you look, can get injured. You got the collarbone, it can be fractured. First you have deeper in here, which I have a picture of the labrum, if you have a shoulder dislocation or something, get injured. And then the big, strong muscles that surround it to try to protect the joint. Looking deeper in the shoulder with the ball removed, the infamous labrum. It's just a soft tissue gasket that's just trying to make the socket a little bit deeper. And that's probably the less important thing it does. The more important thing it does is it's a point of fixation for the ligaments, the glenohumeral ligaments that provide the shoulder stability. So it gives a place for those to attach. And you have a bunch of them. You have the one, starting in the front, the superior, middle, and then when you dislocate your shoulder, it's usually this anterior, inferior that gets stretched, the labrum down there that all gets stretched out and injured. Posterior labral problems less common unless you're a lineman in football when you try to shove your ball at the back of the socket. The rotator cuff, unfortunately my picture didn't come out here, but every day in the office I explain this to people because people just don't understand what it is. You guys probably have a better hand on it, but it's actually 4 muscles and 4 tendons. It's not really just one big thing. But these 4 muscles and tendons, they do work together, but they are distinct entities and they do very different things. The subscapularis is the big tendon in the front of the shoulder that kind of turns you in. The infraspinatus and teres minor are the 2 in the back that rotate you out. And all of the rotator cuff muscles live on your shoulder blade. They live back here, but then they come over and form tendons and attach to the ball. So when the muscles fire, the shoulder works. The one that gets injured the most is the supraspinatus. It's the one throwers, swimmers, volleyball players, anybody that's doing anything overhead, guys weightlifting a lot, that's the one that typically is the one that gets injured the most and is very vulnerable. But the main function of that rotator cuff is to steer and hold the ball in the socket so the big strong muscles can work, the pec, the deltoid, all the muscles in the back. And when that rotator cuff starts having problems, the whole system gets all messed up. It's like trying to drive a car without power steering. You're just going to start wrecking into stuff. And then sliding up in between that rotator cuff, your biceps muscle has 2 heads. One of the heads, the long head, sends this really wimpy, pathetic tendon up into the shoulder. We don't even really know what the exact function of it is, to be honest, because you can't, when you test it or cut it, it doesn't seem to do a lot, but it can be a source of pain. So it's important for us to know about. Getting into this common injury, shoulder instability, dislocations. You'll hear a lot of this, kids feeling the sensation of the shoulder slipped out or not sure what happened. So that would be more of a subluxation where the ball slips in, slips out. So you just feel something happen, you're not sure, and you hurt. Versus an overt dislocation where the ball completely goes out of the socket and gets stuck. Those are the kids that are holding their arm, depending on the position, but it's usually down, can't move it at all because that ball is just stuck against the front of the socket. And when you do that, whether you have a subluxation in and out quickly or a dislocation, lots of stuff can be injured. That labrum that deepens the socket can get hurt because the ball's sliding right by it and shearing it off the front of the socket. Those ligaments that attach to the labrum, they can get torn or stretched. It's just because the ball's falling into them and stretching them out. And then sometimes you can have different fractures. If it's a really high energy, particularly in sports like football, just where there's big collisions, that ball can hit the front of the socket and actually chip a little piece of bone off with the ligaments and labrum. So different things we look at, and then we get x-rays. You can see that shoulder it should be up here. Here's the socket, so it's kind of out the front, inferior front, which is pretty common. And that's when you just try to get those muscles relaxed, get them to pop it back in. If you're ever on the field and you're struggling with that, the key is just, and again, sometimes it's hard, sometimes it just will not get in, but just trying to get the kid to relax. A lot of times, even if you have a table, lie them on their stomach, just let it hang, even pull a little weight, and then eventually, once those muscles relax, it just kind of will pop back in. This is, again, that labrum. And again, the labrum attaches right to the front part of that socket, so it'll just get ripped free. And a lot of times, moving on to the next slide, what do you do about it? A kid dislocates their shoulder, you sublux it. Typically, you rehab them. It heals, and they do okay. A lot of it, though, depends on the sport they play, their age. So if it's a collision sport, any sport where you're hitting somebody, they're higher risk of recurrence. The younger they are, teenagers, all the high school population, extremely high risk. I'll usually just see them that first time, evaluate them, see how uncomfortable they are. If they seem like they're really banged up, a lot of times I'll get an MRI because there are things on an MRI that could tip off to me that this is a shoulder that's probably going to stay unstable. So their chance of them healing and getting better on their own may not be as great. I usually give everybody 6 weeks at least, and then I'll re-examine them and just see how unstable they are. If they get up here and they just feel like the shoulder's coming out, there's a good chance that's a shoulder that's probably going to need something done about it. Doesn't always mean you have to do it right then and there. You can try to nurse them through the season. And then if there is recurrent instability, if somebody's playing football and they're slipping in and out, at the end of the year you're going to probably have to deal with that. Fixing it, kind of depends on what it is. If it's a straight labrum ligament problem, it's pretty darn easy for us to fix. Just kind of go in there and grab everything and tighten it up. I tell the kids I'm going to go give their shoulder a wedgie, and they can usually understand what that means. But it is a decent recovery. You have to get those soft tissue structures sealed back to bones. That can take a good 4 to 6 months. And again, the younger kids, wrestlers, football players going back, they are still ones that are even fixing it. They're really high risk of it happening again just by the nature of what they're doing. This is kind of what it looks like arthroscopically. We basically go in, put these bone anchors in, grab the labrum, and just sock it right down to the socket. You're just tacking it down and tightening it up. Moving on to shoulder separations, which is injuring the AC joint, which is right in the top of the shoulder. I'm sure a lot of people in this room have done this. Anytime you fall right in the tip of the shoulder gets forced down and all the force goes right through that joint. We have in orthopedics, like we do everything, I think to make us feel smart, we classify everything, which does help though too, figure out how bad's the injury. If somebody falls and there's no deformity, it's a little sore, that's kind of a type 1. And then as the injury gets worse, you start tearing more and more ligaments, the grade goes up. So with these injuries, a lot of times you'll see somebody come in and their collarbone's sticking up by their ear. You can pretty much know that that's a pretty high grade, like a type 5 AC separation. There's a good chance we're going to have to do something about that. If they injure it in a very common, this type 3, where it'll just be elevated a little bit, those you can usually let heal and people will do okay. This was just a girl I had. A lot of bicycle accidents. I feel like I'll see a lot of people go over the handlebars and boom on the shoulder, but she fell on her bicycle. And you can see over there, this is normal shoulder. So I'm measuring the distance from this bone to here. That's about normal, like a centimeter. And you can see this one, 2.5 centimeters, and the collarbone's way high in relation to that. So even that, anybody would see the collarbone up. So that was one we ended up having to fix, because that will cause long-term issues. Again, treatment, usually the lower grades, 1 to 3, typically let them heal up. If it's an athlete in sport, usually grade 1, we say 1 week it takes to get back. A grade 2 is 2 weeks, grade 3, 3 weeks. But everybody's different. But typically with time, they will get better and do okay. The higher grades, a lot of times those are the one we have to fix. And you basically go in and just reconstruct those ligaments. And again, that's a pretty long recovery. Because you're reconstructing ligaments, you have to get those healed. So usually 6 months before I'll let them get back to any physical, really contact sports. Clavicle fracture is extremely common. It's the most commonly fractured bone in the body. Most of them you let heal on their own. My dad's a retired orthopedic surgeon. He thinks we're crazy that some of us are fixing them now because he's like, I let them heal forever and nobody had problems. That's not necessarily true. Some of the fracture patterns we've learned through our literature, they don't do as well as we think. The shoulder function gets affected. It's not as strong as it used to. This was a kid I had a few years ago. If I can get the pointer on it, you can see the end of the collarbone right there, a sharp piece. This is a big fragment. This is the other piece. That's a pretty bad injury. This big fragment spun like 90 degrees. It's tenting his skin. So I ended up fixing that. But again, most of them aren't that bad. Most of them are kind of either tilted or just off a little bit, and you let them heal. I tell mostly everybody if I am going to treat them without surgery, they're probably going to have a bump, and it's going to be there forever. It's rare for that to go away, but the function of the shoulder should be pretty good as long as it's not one of the specific fractures that we worry about. And again, this is what I did. If we are going to fix it, they just get a big plate. So you tell them you're probably trading a bump for a scar, and you put that plate on and let it heal. Moving on to the more chronic conditions, just to stay on time. Shoulder impingement is incredibly common. I dare say everybody in this room over 30 has probably experienced this at some point, but it's when the rotator cuff gets inflamed as it comes through this outlet in the shoulder, and it starts rubbing and impinging against the bone that lives above it. Get that pointer to work right up here. So it starts rubbing against the acromion bone. You got a little bursa sac there, and then what happens is as that rotator cuff rubs, and if you ever hear any cracking and popping and grinding your shoulder, this is what's going on. The tendon gets inflamed, and again, that rotator cuff tendon is a steering mechanism for the shoulder. So when it gets inflamed, it stops working as well as it should, and then the shoulder starts aching, it gets out of sync, and then pain. People start experiencing pain, particularly at night. You'll have weakness in certain positions. You reach for something, it just hurts. Impingement, it can be from the rubbing phenomenon, but any reason that rotator cuff may not work well can cause that as well. So if you have a strain to the rotator cuff or a rotator cuff tear or a nerve issue, any reason to make that rotator cuff not working as well can let the head slip north and start rubbing against the bone. So that's a little bit more detail than you probably need, but then it just causes this rubbing phenomenon. Typically you can get away with therapy, a lot of posture. The more we sit forward, the more the bone at the top of the shoulder dips over the front, and the more we rub against the rotator cuff. So I'm always trying to tell people, and trying to preach to myself, get those shoulders back. Mom was kind of right. Posture actually does mean something when it comes to shoulders. Painful conditions, a lot of times you can use cortisone. Cortisone absolutely is a temporary fix. It is a Band-Aid, as we call it, but that cortisone can decrease the pain in that area, and then you send people to physical therapy, and it makes the therapy so much more productive. So those exercises can actually work, and then they can get over it. So even when the cortisone wears off, the shoulder's typically in a better place. A lot of times if you just send people to therapy and they're really having pain, the therapists they can't make it happen because it hurts too much. They can't do the exercises. And again, there are surgeries. If you fail everything, pain, you can go in there arthroscopically. These are some pictures. I take this burr. This looks humongous. It's only about 4 or 5 millimeters, and I grind down the roof. I actually am raising the roof of the shoulder, that acromion, so you can't rub as much. And you clear out space. It's called a decompression. That a lot of times can help. And it is relatively easy surgery, but obviously not something you want to do if you don't have to. Pretty quick recovery. A decompression surgery, I tell people 2-3 weeks they're having surgical pain. By 4 to 6, most people are doing a lot better. If people tend to heal with a lot of scar tissue, diabetics sometimes are prone to frozen shoulders. That'll slow down the process. But this is one of the few things I do in the shoulder that actually is a relatively quick recovery with minimal time in a sling and relatively minimal downtime. And then moving on to the rotator cuff, like I said before, the rotator cuff compresses and keeps that ball in the socket. So it's kind of the holy grail of the shoulder. When it starts having problems, whether it's inflamed, it's torn, it's partially torn, the nerves that go into it don't work, the whole shoulder gets itself out of sync. And that's when, and again, you lose the steering mechanism, the ball starts swimming around the shoulder and just starts dinging everything like a pinball and inflames the whole thing and becomes a problem. Rotator cuff tears, again, just for your knowledge, you hear about these things so much. again, when we say rotator cuff tears, you could have, remember there's 4 tendons, so one of them could be torn, 2 of them, 3 of them. I don't think I've ever seen all 4 of them get torn, but if you have a traumatic episode, you fall off a ladder and jam your shoulder up real bad, those are ones that can tear multiple tendons. Most people, if they're just run-of-the-mill, kind of everyday life, work and have problems, they'll start injuring maybe one tendon like that supraspinatus that's doing all the work, and then when we get MRIs, you can see a tear clearly. This is the end of the tendon right here. This tendon should be attached to the bone right there. So what happens is the tendon pulls off the bone, the muscle that's connected to that tendon almost recoils like a spring and pulls the tendon further away from where it's supposed to go. That's why I tell people when you have it's impossible for that to heal on its own. Now the shoulder may recover, and you may do therapy and you have a shot and you feel better because the other muscles compensate and pick up the slack. But one thing I tell people, you have a full thickness tear like that, it can't heal because it's just pulled away from where it's supposed to go. And that's where sometimes if they can't get over the pain, we go in there surgically and reattach that to the bone with these bone anchors. Again, lots of different ways you can hurt the rotator cuff, traumatic things, work-related, genetics play a part. I have a whole new respect for physical guys, carpenters, steel workers, laborers, masons. The more you use it, the more mileage you put, the more stuff starts wearing out and you hurt it. If you don't do those things, you tend to last a little bit longer. Guys that lift a lot of weights and want to lift heavy, they turn the shoulder into a weight-bearing joint. I'm not saying it's bad, it's good to be strong, but you definitely wear out the shoulder quicker. It's just like a tire riding on the highway. How many miles does it have before it blows? So everybody has a limit to it. And again, the exam, pretty much you can, just listening to somebody talk almost the majority of the time will let me figure out what's going on. And then usually I'll use my exam to confirm. You can test each one of those rotator cuff tendons because they do different things. So I can really figure out typically which one is involved and how big the problem is. And then you can figure out, do you need an x-ray? Are you worried about a fracture? Do you need an MRI? Or can you just send them off to therapy and rehab it and you just kind of figure out your plan? Just a couple simple things. I mean, larger tears are felt to be more symptomatic, but as crazy as this sounds, that's not always true. I'll see some elderly people with humongous tears and the shoulder works well because the other muscles are compensated and they really don't do that bad. Whereas I'll have somebody younger, 40s, 50s with a small tear and they're very symptomatic. It's killing them, it's keeping them up at night. So that doesn't always make a lot of sense in my mind. You'd think bigger usually means worse, but it's not necessarily true. We do believe that those tears can get bigger over time. And I think the reason for that is all those tendons work together. If you've torn one, the other 3 are picking up the slack. So they're getting more tension. It's like a suspension bridge. If you knock out a few of the cables, all the other cables are taking more slack. So if something happens to them, they fall and then the whole bridge can fall in the water. So that's where I tell most people it is our belief that it gets worse with time, but we haven't actually ever totally been able to prove that. Which seems another kind of crazy orthopedic thing. Chronic tears, I talk to people, you have a full thickness tear like on that MRI, depending on the person, most of those people, I'm going to push them to fix it. Because my worry is we have a window on that. That tendon that's torn with time will go bad. It'll kind of degenerate. I always say it's like putting lumber out in the Syracuse winter and coming back in 2 years and trying to grab those 2x4s and building a house out of. A lot of those pieces will be rotten. Same thing with the tendon. When the tendon's torn, it starts breaking down and going bad. So, and I'm not saying you got to immediately go do it, but I don't want people to think that, hey, I'm going to come back 2-3 years from now and go fix this, because there's a chance it may have gone away. And then the muscle connected to that tendon, it atrophies, it shrinks in size. And so even if you do go in there and fix that tendon, people can have chronic weakness because that muscle's weak. The pain may be better. So it's not ideal. That's a whole conversation you have with patients. Again, conservative management, rotator cuff tears, partial tears, inflammation. If we can get the inflammation out of the shoulder, get the shoulder working better with therapy, a lot of times we can do okay. If we fail that, or full thickness tears that are very symptomatic, those are things sometimes they'll think about doing surgery and fixing. I think that was my last slide. That's it, guys. Thanks. Does anybody have any questions about anything? Nothing? Usually somebody has a personal thing they want to bring up. But we're good? Now, we got cortisone in the back if anybody needs any shots. I bring a special supply with me everywhere. All right, well, thanks for coming out. It's Saturday.